Hello. Today I was supposed to have a conference call with a new infection preventionist, and we were going to go over the infection prevention and antimicrobial annual review program process. And I'm not sure what happened, but the person couldn't make it. So I'm trying to make the best of my time and thought it would be great to record a brief webinar, video, whatever, about this process, because we see a lot of questions on the APIC IP Talk platform about the annual risk assessment, the annual summary or review, and the infection prevention annual plan. What you're seeing on the screen, actually, let me stop and tell you who I am. I'm Rebecca Batches. I'm a board certified infection preventionist. I have a master's degree in public health, so I'm not an IP with a nurse background or lab background. And last year, I actually was awarded my fellowship of APIC, the FAPIC. And right now, I work as a senior clinical advisor for Diversey, which is a global disinfectant manufacturing company. But my role is actually to support fellow infection preventionists. I don't sell any product. My salary is not dependent on how well or poorly the company does. Really, my role is one of support to my colleagues. So for me, it's a dream job. And I get to spend my time doing something like this, reaching out to my colleagues in infection prevention, particularly my new colleagues who a lot of the times are working on their own, and they have a regulatory or accreditation survey happen, and they really feel at a loss because they don't have any resources to help walk them through the process. That's the point of this video today, and I'm hoping I can keep it pretty brief. It's not going to be high tech, and I'm still recovering from laryngitis. But again, I wanted to make the best of this opportunity, even though the IP I was supposed to meet with couldn't make this call today. So actually, 2 minutes before the call was supposed to start, I drafted up this diagram, this cycle relationship, and I thought this would be a good starting point for any new infection preventionist who is looking at having to do a risk assessment, annual plan, and then subsequently a summary. And this is actually a really great time of the year to do it. So if you're watching this video, I'm recording it. It's January 16th, 2023. And this is really around the time of year where a lot of infection prevention departments are doing exactly this work. They're looking at what happened in the past year, which is your annual infection prevention and antimicrobial stewardship. We've added this in due to CMS language. This does not mean, however, that antimicrobial stewardship is owned by infection prevention. Antimicrobial stewardship actually is typically owned by a pharmacist. And so be cautious if this is getting put on your plate, because even in a small hospital, someone is driving your pharmacy program, and it should really be a partnership between nursing, pharmacy, infection prevention, medical staff. Medical staff is key. Hopefully you have access to some infectious disease physician resources. If not, you at least need a person trained in infectious diseases to help lead your infection prevention program. However, the language has changed, and they're looking to see your antimicrobial stewardship progress as well. So again, this is a cyclical process. It's actually, in its best form, a constant process where you're always evaluating how well your program is doing and how you're meeting your goals. I'm going to be showing some examples of templates that I've shared, but remember that these are only templates because the whole purpose of your review, your risk assessment, and your annual plan is that it's specific to your facility. And a lot of the times in my past, when I worked for a large academic teaching facility with about 800 beds, my team actually did this in a little office, or maybe we'd go out to lunch, and we only did this together as a team. When I moved to a small hospital, it was actually a great opportunity to bring a team of people together to do these annual activities, because it's not infection prevention in a vacuum. Infection prevention, especially through the pandemic, as we've learned, touches every single department in the hospital. Therefore, when you're doing these types of reviews and assessments and building plans, you want to make sure you have buy-in from facilities, life safety, environmental services, pharmacy, nursing, and medical staff and beyond, right? There's more than just those departments. But depending on the size of your hospital or your facility, you may have different resources, and you might have several people who wear different hats. So let's start just looking at this diagram. As I've mentioned, it's a cycle, and it's constantly occurring all throughout the year. So I think one mistake we make is to wait until the beginning of the year or the ending of a prior year and scramble to start performing our risk assessment, also known as a hazard and vulnerability assessment. And this risk assessment we're going to look at in detail is going to lead into our plan. We want to identify our risks specific to our facility because it might be different than the hospital down the road. So we're going to look at what our risks are, and then we're going to build our plan. And I think it's a wonderful idea that you include your goals so that at the end of the year, when you're doing a review, you need to reflect on whether or not your facility made those goals. And remember, it's not your goal, it's your facility's goal. So I'm going to stop sharing this and pop over to the actual risk assessment. And again, this is just a template. It's just an example. You can find tons of examples and templates on IP Talk if you use the search function. This is just an example of something a consultant, so I want to give credit to Above Water Consulting. When I moved from being in a team environment with 4 fellow infection preventionists, I moved to a small hospital where I was by myself, and I needed to get them up to speed. Many of you are in the same boat, which is why I'm doing this. So let me share my Excel sheet. This is going to be our risk assessment. Sometimes it's called the hazard and vulnerability assessment. It doesn't really matter what you call it. So let's go over to this document. Okay. And I'm going to move it over here. And sorry, again, I didn't really plan on what I would be recording. So actually, I want to make sure I'm picking up the right document. Hopefully this records pretty well. So let's start with our risk assessment. Okay, great. Hopefully this is, yeah, what you're seeing. Again, I'm kind of winging it, so thanks for your patience, and I'm going to try to zoom in on this. Let's go to about 125 so you can see it better. Okay, so hopefully that is appearing pretty well for you. So this is, again, a template. I gave credit where credit's due. This is a template for an annual risk assessment. Most risk assessment templates that you'll come across will have some sort of calculation and scoring matrix where it's going to look at all of your potential risks, and then it's going to calculate, you are going to calculate, but there's some formulas in these templates. You are going to calculate with a team. Again, I don't really feel that these decisions and determination should be made solely by one person. I think it should be a multidisciplinary approach. What we're going to be looking at is the probability of that risk happening, the potential risk or impact on your organization. And then we're going to be looking at your preparedness for this event. If it happens, how well are you prepared? So this is an example that I used, and I was at a smaller, it wasn't an ambulatory surgical center, but it was a smaller hospital, acute care hospital. And we did a lot of surgeries though, so it acted similar to an ambulatory surgical center. So what we have here are our different categories of infection, multi-drug resistant organisms. We've added in antimicrobial stewardship, which is consistent with the current CMS regulations. Again, you shouldn't be doing this on your own. You should be performing this risk assessment. And when you're talking about antimicrobial stewardship, I know I sound like a broken record, but you really want to bring your pharmacy folks into this. And if you have the resource, your infectious disease physician. Prevention is another category. Communication, environment, which can be a very broad topic, as you see here. And then employee health. We have special populations, the community overall, disasters. And then there's a spot here for other where you can actually modify again, and you're encouraged to do so to make this risk assessment meaningful to you. Now let's take a step back and think about how this is used in the regulatory process or accreditation process. A surveyor or accreditation specialist is going to be coming in, and they're going to be sitting with you, and they want to know that you know this document and the others we're going to go through inside and out. If you cannot speak to this document, there's a problem and you might be cited for it. So you need to make this work for you, for your facility. And ideally, you should be turning to this. You can change this throughout the year as well. Things might change in the middle of a year and you can go back and change this. And you can also make that change in your annual plan. I like to think of the risk assessment as step one in the cycle, where we're identifying what's at risk, what our facility is at risk of experiencing, and then we build our plan off of that. So we went through each category. Now, again, you'll see examples of how I modified this to make it work for me. I actually added new categories in, and you'll see that purple categories that are highlighted in purple in this row, they are something that I added on that wasn't in the original template. So that just goes to show that not every facility has the same needs, and you can use this as a living document. What I highlighted in yellow would have been what increased in risk from last year to the current year. And so if you have a template from last year and you don't like it, you can get a new template. But the whole point of this exercise is that you're looking at what your facility is at risk of experiencing and how you and your organization plan on responding to it. So let's look at this in real time. Let's try to do this together. So starting with my HAIs, this was, again, used for a surgical hospital that performed laminectomies, lumbar fusions, etc. So what was the probability that someone was going to get a surgical site infection after an orthospine? And this is just example data. This is not, I'm just going to be making stuff up at random. It does not reflect any of the past organizations I've worked at. So let's say probability. If I had a higher than expected number of infections based on my historic data, because if I don't enter these into NHSN, then I might not have a standardized infection ratio. If you do enter them into NHSN, that's great because you'll have an SIR or standardized infection ratio from year to year, and you can see if you've increased or decreased. So you want to look at each infection type and say, how probable is it that someone's going to get an infection? If you had an outbreak last year of Staph aureus infections in this population of surgeries, you might want to say it's 3, likely. Now we're going to calculate the risk or impact. If you didn't have outbreaks, by the way, you could call this rare, and that would be fine. Let me make sure these calculations are, okay, good. There's a formula built in that's going to give me a score, which is really important for us to look at. So let's say if I had an outbreak and we were struggling with orthospine infections and I said it was likely, now I want to say, what is the risk or impact of that infection? We want to give it a score of 1 through 5. So for an SSI, our worst case scenario is death or permanent injury, right? So I could score this at a 5. And you see how the score has changed to 38%. That's because I've said it's likely to happen. And the possibility of death or permanent injury is a 5, which is the highest score. So already I'm at 30%, 38%, which is a high risk, because we're going to look at the, when we look at these scores together, we're going to see how we build our plan, and we build our infection prevention plan on the highest relative risk items, because the reality is we can't do everything all the time. We need to use these documents and these assessments to help tailor our approach. Okay, so we said that if you had a spine infection, now you could argue this, and this is where it's important to work with a team of individuals, a multidisciplinary team. An orthopedic surgeon might say, let's say it's temporary physical loss, and that would change your score here. If I remove, it goes to a 30%. So hopefully you're seeing how this works. Now, what is our preparedness to deal with that problem? Do we have a good surgical site infection prevention plan? Do we do things like decolonize our patients before these types of procedures? Do we assess them and provide education? That is your assessment of what your surgical site infection prevention for this type of infection is going to determine your score for preparedness. If you have a wonderful pre-surgical program, you can give yourself a 1. And any score you would have given, you're still going to have a 38% here. Now, if you never had an outbreak and you're doing really, really well on your orthospine infections, let's take that down to a rare. And now you see your relative risk score has changed down to 13%. So again, if you want to look at how this is being scored, you can click the formula box and it shows you that it's adding each of these numbers and dividing them by the overall potential score. And that's how you're getting this percentage. Most risk assessments or hazard and vulnerability assessments work in this way, where you're getting a percentage of the risk popping out at you. So let's go to a different category. What we want to be able to determine at the end, and you see how I color coded this. So I need to say, I'm scrolling down because I want to show you something. I've determined at the facility that I worked, sorry, I had a text, that the facility that I worked in, I wanted to say indicators with a relative risk over 30% will be included in the infection control antibiotic stewardship annual plan goals for improvement. So whatever scored the highest risk here, I'm going to write a goal for that. So let's look at another topic. This is near and dear to my heart. And a lot of risk assessments might not even include this, even though it happens all the time. With climate change, we know that there's increased flooding. Right now in January 2023, California is experiencing exponential amounts of rain. And so in my former template, water intrusion was not there, but I added this in. And then I color coded it as yellow because I increased the risk from the year prior when they said they never had any floods to the year I worked, when they actually had over 5 floods in the 10 months that I worked there. So for me, doing my risk assessment with a team, water intrusion, I didn't say 4 expected, but I did say 3 likely given the last year's occurrences. Risk or impact, Now, this is where we again see that this is a somewhat subjective a decision-making process. And that's why I think having multiple voices at the table is important. Now, sometimes too, you might see the terminology not exactly equate. It might be reflective of patient harm, but the risk impact, we really want to be thinking if it's something like flooding, not only is there risk to patients, but to our employees and also to our actual physical environment. So prolonged length of stay doesn't apply to flooding per se, but we really want to think of is there a disastrous element that would list it as a 5, temporary physical losses and damages. Certainly that sounds like what may happen with a flood where you have to toss a lot of materials that got damaged with flood water. 3 would be prolonged length of stay, but you could say that's a midpoint between 5 and 1. Moderate clinical or financial impact, and then minimal. For me, in my experience, and yours might be very different, I'm going to call this actually a 4 because we've had to do a lot of construction and remediation after flooding. Preparedness with the current system. If you don't know how you're going to respond to a flood, don't score yourself as excellent. If you don't know what you're going to do and you have a flood happen and your facilities team can't respond to it and nobody else in the organization knows what they're going to do, call it no process, no policy in place. This is going to really put your score very high, 68. And that means in my plan for next year, I'm going to call water intrusions into my annual plan and I'm going to write a goal. And my goal is going to be that we're prepared to respond to a water intrusion or flooding event. Does that make sense? Now, in the following year, if you have a dry year, you can actually take this down to rare and it changes your score down to a 23%. So if you've got a good process in place and you feel good, then in the next year that you do your assessment, this score will change. And again, I hope this is making some sense. So we do this with everything, with every risk that we can identify related to infection prevention. And I think this is a great template. Of course, I'm biased because I actually used it. You go through and look at each of these and again, talk to the teams. I would like to spend some time on building the annual plan. And so I'm going to stop sharing this and go to a different document. And there's probably a smoother way to transition, but I haven't figured that way out. So let me go back to sharing. Hopefully I haven't gone on too long. Okay, let's share our infection prevention plan. And let's zoom in on this a little bit more. Hopefully it comes across really well in the recording. And I'm going to scroll up to start at the very beginning. Here we see an example. And again, I'm going to be the broken record and repeat that these are all just examples and templates. They need to be customized to your organization. And you need to be so familiar with these that you could recite them in your sleep. Really at any point, if any person asks you, whether they're a surveyor, a board member, physician, nurse, anybody, if they say, what are our top 3 problems in infection prevention and control here? You should be able to answer them without a doubt. So this we've done, let's say we've done our risk assessment. Let's move into our plan. The risk assessment leads into the plan. And this again is a template. There are many online. There are many available through APIC IP Talk. This is just one that I had available to me and it worked for me. Typically, you're going to see these sections. If you have a plan that's only 3 pages long, you have a problem because there's no way that any healthcare facility, whether it's an ambulatory surgical center or a large academic medical center with a level 1 trauma emergency department or a skilled nursing facility, there's no way you can encapsulate the complexities of your infection prevention program in 3 pages. So take that as a tip. If you have a 3 to 4 page infection prevention plan, you need to start reviewing it and revising it. So you can see already here that this is a 17-page plan. Let's go over, you can use the same template and then change things as you need to. This starts off with a purpose, and this is a pretty generic purpose. The risk of development of an HAI is minimized through a system-wide infection prevention and control program. The purpose of the infection control program at X facility, which includes all affiliated sites, because a lot of places have outpatient practices under their regulatory responsibility, is to influence, support, and improve the quality of healthcare through the practice and management of infection prevention and control, et cetera. So you go through, you want to review this carefully, and you want to add in, critical to a successful program is communication and collaboration. You want to speak to what your policies and procedures. The hospital uses evidence-based national guidelines such as, now don't go crazy here, because you want to stick to what's in your policies and procedures. It speaks to the responsibilities of the infection preventionist. Again, this is a plan from an institution where I was the only infection preventionist. The next section speaks to how we develop the annual plan. And this is just what we were talking about with the risk assessment. So read through this. The annual plan design is prioritized based on the risks identified in the infection prevention and control hazard and vulnerability assessment. And then I even link it in there so that nobody has to search around for what they're looking for when they come on site. Again, you can read through these specifics and update and customize as you see appropriate. Authority statement. This is something that CMS is looking for. And so there should be a separate document available that actually has signatures of your governing board or the equivalent guiding board of directors that makes decisions. They're looking for an authority statement that actually states that you were chosen based on your credentials, your experience, et cetera. Next is the care and services. You really, and I have a note here for the people I share this with, this needs to be customized. You cannot copy and paste this. You need to write an overview, and somebody else in quality management or risk management might already have something like this, but you really want to speak to what your overview is. So this says assessment and services in patient population at X facility and another facility included within that scope allows us to tailor a plan to reduce horizontal transmission, blah, blah, blah. So again, you're really seeing, we're looking at how many surgeries do we perform, how many campuses do we have outpatient practices, et cetera. This leads into a table that was part of the template and the frequency that would happen. And this should be in alignment with the risk assessment you just performed. These are some of the top HAIs, and again, their frequency. There's more detail about the specifics to your organization. So please really give this a lot of thought and then have someone help work through it with you so that, especially if you're a new employee, you might not be the person that knows the background of that organization. Your annual plan should also include an assessment of the population in the community you serve. Your community might be very different than my community. If you're working in a rural hospital in Utah, you have a very different community than me working in a level 1 trauma center in Detroit, Michigan. So think about that. You want to pull in the information you do have. Look to your state health department and the reports they produce. Here I mentioned the tuberculosis rates and how Michigan's doing. That's where I live, Michigan, obviously, etc. You can see here that I've really customized, and I'm telling a story. I'm telling a story of this infection prevention and control program. There wasn't any tuberculosis data published in 2021. And so I tell that in my annual plan. Please note, due to the COVID-19 pandemic and limited public health resources, the county in which my organization resided didn't have the data. But that doesn't mean I don't write anything in my plan. The IP continues to monitor regional communicable disease surveillance. Then I look at what was happening in my state. In February, in my state, a health alert network communicated to me an increase in Candida auris cases. That's significant. Put that in your plan. And I hope, again, these sample documents can be given to anybody upon request using my email address that will be shared. But I hope you're getting a sense that this is really a story that you're telling. It's also a reflection of all the hard work you're doing. So don't forget that. So we had looked at the risk assessment, and I'm going to show you, and this again is an example from a facility on what we determined were our top priorities based on the risk assessment. And from that risk assessment, remember that we stated at the bottom, anything over 30% relative risk of occurring, we were going to we were going to add that specifically into our plan. So let's talk about some of those examples. The year I worked here, it was a huge focus to get our COVID vaccination and boosters up. And I think that's still a goal with a lot of healthcare facilities. Because we didn't have a great process, that was scored as high as 45%. So you see here, it's number 2. We did a lot of hand procedures. And so hand surgeries, I should say. And so we want to keep that top of mind. And that also scored very high with us. Maybe during a regulatory survey, we couldn't provide documentation of our negative pressure in soiled rooms and our positive pressure in the clean rooms. And so we bumped that up due to something that happened within the year to prepare better for next year. I think with all of us, high-level disinfection and sterilization will always be calculated at a high risk because we're always learning and always developing. Again, if you don't do these types of procedures at your facility, then they wouldn't be reflected on your specific infection control plan. So from those risks, I wanted to write specific goals in response to those. What am I going to do? And then at the end of the year, I need to look back at these goals and I need to say, did I meet them? Was I successful? And if you didn't, that's okay. So let's look at some of these example goals. One of my risks was that I wasn't getting microbiology results back, something very simple, but cultures were being taken intraoperatively and I wasn't getting the results. How could I detect a cluster of surgical site infections if I didn't have the culture results? So one of my top priorities was to partner with the lab to monitor and improve turnaround time in communicating reference laboratory cultures back to the providers. And this made them happy. It made them happy just to see it in writing that it was part of my goal, right? You see now how this starts to become a living document that's not something that's a tedious task, but it's actually a way to show that you're meeting your goals and all the work that you're doing. So my goal 2, make it a SMART goal. That means it's specific, it's measurable, it's achievable, it's trackable. I think I said measurable, but I don't have the SMART acronym right in front of me. I think you guys get what I'm trying to say. So I needed to put a concrete goal around that vaccination goal that I mentioned, or risk that I mentioned above. 80% of employees will be considered up to date with COVID vaccination per CDC definitions. Now, at the end of the year, if I'm only at 65, that's okay. We'll just talk about it in our summary and talk about what we're going to do the next year. So hopefully, again, this speaks to the process. You're identifying your risk, and then you're creating goals based on those risks. And now you're going to monitor it throughout the year. Let's look at that. This template was also provided by Above Water Consulting that helped me as a new IP when I was all by myself at a new facility in the past couple of years. What I loved about this template is that it actually broke down per quarter. How was I doing? So don't just wait till the end of the year to look back on your successes. Use this template as a living document. So let's go back to this example of delay in reference laboratory, microbiology, and culture results back to the ordering provider. And what are the impact here? You can see I'm very passionately tied to this. This meant that we could potentially provide inappropriate antimicrobial treatment, worsening infection, and patient harm. This was one of my top goals. You might never see this example on any other facility's risk assessment because it might not be a problem for anybody else, but it was a problem for me and my institution. So the goal, improve the turnaround time and communicating that lab result back to the ordering provider. Pretty simple. What are our strategies here? Okay, you gotta put in the work. So again, this is a lot of work. We had 13 high priority risks that were greater than 30% relative risk. But if they are that high risk, then I have to be able to respond to that. This is the whole purpose of why our regulatory partners are looking at this. They want to be sure that we are prepared to respond to the things that are most likely to cause patient employee harm. So each quarter I have here in bold, describe if the facility was non-compliant or compliant and provide some statistics around that. Or if you don't have actual data, like you might have with CAUTI or CLABSI or surgical site infections, you can just make a simple statement. So what were the metrics, and describe how you did per that specific risk, and then what is the control or activity to continue to improve it. Okay, so let's see if we have a better example here. Surgical site infections, hand procedures. Let's say we said we want to reduce hand SSIs by X percentage. How are we going to do that? We have several methods. We're going to monitor our laboratory reports, returns to the operating room, patient safety event reports, satisfaction surveys, and our daily antibiotic reports for potential SSI. This is the nuts and bolts of an infection prevention surveillance program. The OR staff is going to report any suspect SSI via an incident reporting form, because we should all have a safety reporting system in place. Perform a root cause analysis of any potential SSI. IP is going to be, the IP, which was me, was going to be performing OR observations for at least 3 cases per quarter per location. And then I'm going to enter the surgeon SSI data into a dashboard, a quality dashboard that would be fed back to the surgeon. These are all very achievable strategies to reduce SSIs. I hope you agree. Now I need to say in each quarter, what was the rate or how many infections happened if you don't have a rate, and then what my action is. Even if it's continue to monitor, that's okay. But if you stay on top of this every quarter, what actually ends up happening is that you have your annual review built into your plan, which makes your next year's risk assessment even easier. I am going to stop sharing. I hope that that has been very helpful. Always go back to that cyclical model, thinking about your annual risk assessment, which should be performed ideally at this time of year, the very beginning of the year. Take your highest risk items and start building that infection control plan. Don't create goals that aren't achievable, right? Don't say that you're going to be in the OR every week if your schedule doesn't allow you to be in the OR every week. And you being in the OR every week, is that really necessary? Probably not. With sterilization and high-level disinfection, make achievable goals. How many tracer rounds are you going to do? Build that into your plan if that's a vulnerability for your institution. And I guarantee if you start becoming very knowledgeable of these 3 documents that we talked about, the risk assessment, also known as the hazard and vulnerability assessment, the annual plan, and the annual summary, which is a comprehensive review, and others might have program evaluation or annual program evaluation. It doesn't really matter what you call it, but you have 3 key components, and you are the author of the story. And you don't want to just show the negative. The annual plan, review, and risk assessment is a wonderful way to show all of the work you're doing every single day in infection prevention. So I hope you find this video helpful. I am going to put my contact email in the comments, I guess, where I post it. This is the first video I've ever done of this type to really help new IPs. And so if you enjoyed it or you have any suggestions for improvement, please let me know. And with that, I'm going to stop recording.